I was asked to give a short introduction about this concept about status neutral approach, and to be honest, I had to go through a bit of a literature as well, a bit of an academic approach as well, because it was laid out in scientific literature to some degree during the last years. This is one of the papers that firstly described and summarized this concept, and it's something that as you can see on the left-hand side, is also depicted in a graph, which I will come to in a second again. We start with something more linear and not circles, which we will end up, but with a linear thing, which probably reflects a bit more my life as a physician and HIV specialist. And it starts with HIV testing, and then people may be diagnosed, and then we've got this linkage of care that we've been discussing the last years very often, and we set goals of 90, being treated, being efficiently treated, and so on. But the HIV testing here in this graph also has very important wording below, bar before the bars. The test system, the testing itself is a bar, but there's many bars before that. And this is what we've talked about before we had the reports, everything that is around stigma that prevents people of having a test, approaching or getting those also offered. So there is stigma and also prevention in offering these tests. But I think it's very important that there is the left-hand side, and that was kept on separate for many, many years. So we've talked about this before. This was crucial. There's two crucial things for this concept of status neutral approach. The one is the U equals U, and I agree fully. I see that every day when I try to explain this. Either you get asked, is that really true? I've heard about it. And others that you tell U equals U, they ask, what exactly does it mean? And then you go through all these conditions, situations like pregnancy and sexual transmission situations, and it becomes complicated again. But anyway, the second important concept that became true and scientifically supported and more becomes reality is that PrEP works. And not only the oral PrEP, all the new concepts. And that's something very important, because that changes the understanding and the efficiency, of course, of prevention and gives completely different options. Although all these concepts are complicated in itself, but they need services to provide it. So this is, I think, the idea then to develop the other side, the left-hand side. So if you've got an HIV negative test, you still should be supported and should have all the offers and options that one can take out of this information. And it's listed here, so apparently you need to talk about the risk that you might have. Make people aware that there is PrEP, link it to PrEP, prescribe PrEP, and retain on PrEP, if PrEP is the backbone of this sort of left-hand side direction. And this concept of status neutral service takes it to another level, I would say. It puts, again, on the top, as you can see, the people and the test results. And then on the right-hand side, you see, either you've got a positive test result and are retained in care. And you remember probably on the right-hand side, we've got for many years different approaches and different efforts to get people on treatment and, of course, keep them on treatment. I'd like this to rephrase this sentence from that initial paper. Any test result supports action. So whatever it means, it is how you qualify to be tested that makes you a person that needs to be looked after and should seek the advice and the support from different services. So on the right-hand side, I said, we were, and we're still struggling to diagnose people early enough so that they really benefit from treatment. We lose patients off treatment, and there's been lots that has been developed over the last years to try to improve this and the treatment engagement and to have a quality of care and standards of care. We mentioned that before. We try, of course, to define and assure and also measure in different settings across Europe and the world. But there is also the left-hand side, and that is PrEP-driven mainly, but not sure whether PrEP is the exclusive requirement or goal in the end, but this is one that is mentioned, where people should be made aware of the option to receive PrEP, to discuss this by the prescriber, and to get people on PrEP and then keep them on PrEP. And you see, there's also one arrow going back because PrEP may fail. And that can go into the other part of the care if you've done, despite PrEP or other measures, infected with HIV. And we lose a lot of people on the left-hand side. I just put in one paper because I was one of the editors to handle this with a study from France to measure where are the gaps, where is lack of knowledge and lack of action to get people that are at risk, that they understand they're at risk to acquire HIV, where they are identified, supported, and get information about PrEP and are put on PrEP then in the end. Because also it's important to have quality assessment there as well, repetitive HIV testing, STI testing. PrEP is not drugs, it's a whole delivery of care as well. And we know that there is a close correlation. The better you take the pills, or the better these pills are delivered, if you want to, the better is the efficiency, and the more we prevent not only infection but also probably resistance development, which we very often fear. The key point of this is that one tries to put the person first and not the disease. So you don't have to qualify with a positive test result in order to get care and support, but also being eligible sort of for an HIV test makes you a qualifying person to get into this system, either the one or the other way. And the structures that are required for this are, of course, very important to discuss. It's said that you need a lot of around this. I was just thinking about Sally and your case report. What sort of support and structure and infrastructure would you need to support her and then take out HIV? She doesn't have to have HIV for all the problems that you were describing, to make her the difficult patient and to see all that stigma that she's facing. And it requires, again, different partners, different funding, probably for proportions of it, or for different services that you want to include. And I listed some of them, and many of them are very important, and they were mentioned. It comes from training, education, getting people back into work, dental care, lots of other things. And you need them on both sides, you know. It's those patients, we've got the difficult to treat patients, sort of, on both sides, that would need this support. And it goes down to transportation, to access to these services and the care. And it's said that this could be and should be really depending on the environment and the local circumstances, and whether it's London or another city or another place, should also be oriented clearly to what are the targeted population. What are the populations which are most in need and could probably best benefit from this? And there's a few suggestions here which I've taken from literature and the internet and some places where people start to establish this. I think one of the biggest questions, of course, is does this normalize anything? We were talking about normalization. I think we're all struggling. Is HIV something specific, or should it be part of infectious diseases? We are stigmatizing also the people in that, you know, not everyone achieves a viral load below limit of detection. So if U equals U is a quality that you should achieve, what then about those that are not able to do this? And we are also keeping young doctors out of HIV medicine because we're making it very complicated or rather routine and boring. So sometimes I think we don't know really where to go. And the big question we should discuss later on, whether that is really helpful to destigmatize the whole situation and get this out, because we're still talking about people that are involved here. This could be all of us. We're not talking to those which the biggest stigma comes from, which is around. Also, that wording was nice, the sexual transmitted disease clinic into more culturally competent sexual health clinic. I think the wording somehow captures that, it's about the understanding and where you really want to go. What is probably an idea of reaching out to those that don't know much about HIV, it's also the idea that we need to change then the wording and get HIV into a different perspective. This is just some of the examples. Be HIV sure, PrEP, condoms, treatment as prevention, U equals U needs to be campaigned also in order to get the people first and not the test results as the decisive entry. I found that in the end quite a bit funny that this sentence was one of the key summaries of that initial paper, virtually eliminating UHIV infections effectively supporting all people with HIV, and there's something missing, and all without HIV to lead to a long and healthy life and eliminating the disparities that persist among some of these populations. I think what's crucial is really, this sounds to me still like a concept, very convincing, very smart. I think it's the question of how can we incorporate this and what needs to be adapted or developed in order to make this really work. Form follows function, I said in the end. Does this have to be in one building? Does this have to be one service system, one-stop shop? Or how can we establish something like this, depending on the environment? And I'll leave it there, and I'm happy to take some questions. Otherwise, I think we're going to discuss this later on.
Thank you. Thank you so much.